Great. Well, good morning, everyone. Thank you for joining us. We welcome you back to another year of the South Shore Community Partners in Prevention. As always, we're excited to present speakers at our meeting, our general meetings every month. We are maybe less excited that we still have to be on Zoom, but here we are. As I said, we're glad to have the opportunity to keep this going in a safe way as the pandemic lingers with us into a ongoing endemic situation. But I think in our steering committee, we definitely have talked about trying to give content about COVID and about how it's impacting us in our work and impacting all of us in our lives, really. And we're really excited to have Dr. Rediger here to talk about that in his role. But we do go on, and we're happy to have you all here. So I'll just say one more time, if folks are chiming in, if they don't mind, as you're logging on, I should say, if you don't mind chiming in the chat with your name and where you're from, just to take attendance since Kim is not with us this morning, and also to give Dr. Rediger an idea of who we all are and where we're coming from. I'll start off. My name is Mike Jackman. I am the chair of the South Shore Community Partners in Prevention and District Director for Congressman Bill Keating. Excuse me, Congressman Bill Keating. So I welcome you all here today. So just to get through a little bit of administrative business before we get to our grant report, we do need to vote on our last meeting, which was in May. So I know Kim had sent around a copy of the May minutes. So I would entertain a motion to approve the minutes for May. Moved by Deb Shepperly, second. Nancy DeLuca, thank you. Any discussion on the minutes? All those in favor? Opposed? Motion carries. See, we do things above board here, Dr. Rediger. You know, we're not trying to sneak anything through on anyone. We do have one other piece of business to attend to. We've been very lucky to have representation from South Shore Hospital on our board for many years. And because of some transitions in personnel there, folks moving from one position to another, we had Tina Dwyer for many years. And last June, we elected Allison Gillis as part of our annual elections. But unfortunately, fortunately for her, Allison is transitioning to a new position at the hospital. So Karen Peterson is stepping up to become the representative on the steering committee for South Shore Hospital. I'm not sure if Karen's here. Karen, I don't see her little Zoom box here, but just to keep things, again, kind of on the straight and narrow, we would like to have a special election to accept Karen to the board, and unfortunately, sadly, accept Allison's resignation from the board. So Kim did send around a bio on Karen under Article 3, Section 5A of our operating principles. We can call a special election at any time, and using my prerogative as chair to call a special election today. So is there a motion to accept the nomination of Karen Peterson to the steering committee? Vicky? Second by Nancy. Okay, unfortunately, Karen doesn't look like she's here. Hopefully she'll be joining us sometime today. But in the meantime, any discussion or any thoughts on Karen? We've been lucky to have her at a couple of steering committee meetings already. She does great work with the, oh gosh. Well, I know she works with the Blue Hill CHNA, but South Shore, the Youth Health Initiative. I got it right without it written down in front of me. She's worked on with the Youth Health Initiative through South Shore Hospital for many years. So she's been a great addition to the board already. So with that, I would take a vote, and all in favor of adding Karen Peterson to the board, say aye. Thank you. Opposed? Motion carries. Congratulations, Karen, wherever you might be. All right, thank you all. So one of the things we like to do on the board is to hear back from our grantees. and to hear about the great work that they've been doing with the resources that we have shared with them. So we have a mini grants outcome report today from South Shore Conservatory New Heights Partnership. And I'm going to ask Christy, if you're with us, Christy Fabi? Oh, hi, how are you? Fabi,
good, how are you?
Yeah. Good, thank you. How are you?
Great.
Well, we're glad to have you here, and we want to hear about this grant and how it worked out for you.
Sure. So I actually made a mini PowerPoint presentation.
Okay,
I'd like to share.
Yep. Okay, you should be able to share now, Christy. Thank you.
Yep. Let's see. Here we are. Can everybody see this?
Yep.
Yes.
Okay, wonderful. And I will view. Oh dear, why can't I find how to do this from the beginning? Here we go. All righty. So thank you so much for having me here, and thank you so much for our funding. We were able to work with Algonquin Heights, which I believe was New Heights beforehand, so there's the name change. I'm Christy. I'm the Director of Creative Arts Therapies at South Shore Conservatory, and I started in May after the grant was already being carried out, but I got to see some of the awesome work that was being done in my short tenure here as well. So quick project overview. This was South Shore Conservatory. We're a nonprofit community music school in the South Shore, and we partnered with Algonquin Heights, which is a neighborhood predominantly for lower income residents in Plymouth. We are funded, oh, I'm so sorry, that's my dog, $3,500 to serve Plymouth, and we were able to serve over 100 individuals with this grant. Some of our greatest accomplishments came from ukulele classes. We had ukulele classes led by faculty Julie and John Finn. They were really well attended by some banjo, come here. Really well attended by ukulele students. And Amy Tanner, who's the program director, said that classes were wonderful and the students were really committed. So that was definitely a success. We also had drum circles led by Ed Sorrentino. He actually goes by Eddie Spaghetti sometimes. This is how the children know him. His drum circles were attended by over 75 children and adults. I got to go to this one, and it was super fun. As you can see, all different ages. Children who lived in Algonquin Heights, staff children came, staff were drumming, parents were drumming. It was really great, especially during the pandemic. We even got to celebrate the end of the school year together and a child's birthday, and it was really exciting. And we got feedback that you could feel the energy in the air of people finally being able to come together and make music again. So it was really special. And then we also had some story times with Music Incorporated that were well attended. They kept participants entertained and happy. Our challenges came with Zoom and the coronavirus, obviously. All of us are challenged with that right now. We had to temporarily shift some of these programs to a virtual model, which was fine, but the students and the children and the families at Algonquin Heights were getting kind of fatigued of Zoom because they were Zooming every program. So the attendance went down. But we did come up with a solution with Amy, which is that we weren't able to have an in-person ukulele concert like we planned, but Peter Munt, who is one of our faculty and is beloved at Algonquin Heights, has performed for them quite a bit, is going to perform a big concert for them and have a celebration. And Peter and Amy are working on coordinating that now. And then I thought I would just show you all some like really joyful pictures of the kids coming together through music and the smiles, and you can see there's all different ages, and it was really just like a great community bonding experience. So thank you so much for making our work possible. It's been really great to work with you and to work with Algonquin Heights.
That's great, Christy. Thank you so much. I have attended the drum circle in the past. I wasn't able to come this year, but I can attest to the fact that it's a very well attended and enjoyable for the kids event. So I'm glad that we were able to keep it going this year. Does anyone have any questions for Christy or any comments? Well, Christy, thank you so much. We're glad to hear back. And yeah, you know, if you can keep us posted on what happens with the upcoming events that you mentioned, that would be great. Just so we
Of
can,
course.
yeah, thank you.
Yes, thank you so much.
Yeah. Just before we get to Dr. Rediger, a quick word about grants. We, as a steering committee, have sort of looked at our budget for the year, and we are very much committed to continuing our grant program. But we are also very cognizant of the fact that our funding is not as robust as it has been in the past. We rely solely on funding through the determination of need process through DPH. In other words, hospitals, medical health facilities in the district, in our region, when they do capital improvements under state law, they have to redistribute some of the funding from the capital improvement to the community. And in years past, that was always done through the CHNAs, but the state law and the state regulations has changed a little bit. So some of that funding is going to other community projects, not necessarily the CHNAs. So that kind of faces us with a new fiscal reality, unfortunately. So we are looking at continuing our grant program. It's going to be, unfortunately, a little less generous this year. I think folks who recall, we had a behavioral health grant of $25,000 per year. We are scaling that back down to $10,000 a year. And we are looking to limit our total spending on grants for the entire year to about $50,000. And just as by way of comparison, for the last year, we spent over $140,000 on grants. So there's going to be a significant contraction of our grant spending, unfortunately. And we are looking very closely at new grants. I think we'll be prioritizing new recipients. We have had some grant recipients who have been funded many years in a row, and we are going to be looking closely at those and making sure that folks are looking at sustainability going forward. One thing on a bright note, I will say that we have arranged to have a grant writing workshop as one of our general meetings, and that'll be in the spring. And Deb Shepperly, our erstwhile vice chair, has arranged that. So thank you, Deb. So we'll be doing some communications throughout the year to find out what it is, because we want to make sure that folks who have relied on our grants and folks who are part of this coalition have the resources they need to be sustainable and to fund the things that they want to do, other that they are, they are doing their mission. So offering that grant writing workshop will be one way as a coalition that we are helping our members do that. So more information on that, and the grants have been rewritten a little bit. Again, Kim's away, but the website will be updated hopefully within a week or two with the new grant language. So keep an eye out on that. If you have any questions, you can certainly contact me or contact Kim. All right, well, after that bad news, Dr. Rediger, I lead right into you. We are very excited to have Dr. Rediger here with us today. I'm going to read your bio. It's a brief one. Dr. Rediger, Jeffrey Rediger is a medical director for McLean Southeast Adult Psychiatric Programs and an assistant professor of psychiatry at the Harvard Medical School. He has a Master's of Divinity degree from Princeton Theological Seminary and is a very well-known published author in the fields of medicine, psychiatry, and spirituality. And your work has been featured on the Oprah and Dr. Oz shows. So we are very excited to have you. I want to thank Tyra Jackson from our steering committee for reaching out to Dr. Rediger and having you come here today. So Dr. Rediger, I'll turn it over to you.
Okay, well, thank you. It's a real honor to be here. I want to thank you for all you All of you do. As you know, we are in a rather somewhat invisible psychiatric pandemic these days. And COVID has been so stressful for people, and not knowing when this is going to end and when restrictions have to be increased again is very stressful for a lot of people. We are seeing so many people admitted to McLean who have searched for months to find an outpatient therapist or an outpatient psychopharmacologist, too often unsuccessfully. We have the emergency rooms that are just backed up with people waiting for psychiatric beds right now. And so at Beth Israel Deaconess in Plymouth, for example, the average wait for a psychiatric bed is a week or more right now. Sturdy Hospital, it's the same. I was at Newton Wellesley Hospital yesterday, and they told me that they've never seen this phenomenon before, where 60% of what's coming into the emergency room is psych related. And that's pretty close to what's going on the South Shore, it sounds like, as well. It's just so much anxiety and depression and increased substance abuse. And I think, you know, especially among our young people, you just feel how desperate they feel for physical contact. Those who go to college and their college experience is limited to something virtual right now. And that's just not what college is meant to be for young people. And they need social contact, they need physical contact. And it's not just college students, it's everybody. And so I want to thank you for all you do. There is a real crisis going on right now. Our effort to try to mitigate some of that and help is to open another hospital. We are opening on the 20th of this month in a matter of days. We will slowly be opening another 3 units for a total of 68 beds. We've taken over the old High Point Hospital in Middleborough and converted that into 2 adult units and 1 adolescent unit. And so that will help a little bit. It's still a drop in the bucket for what's going on. But that hopefully will help take down some of the acuity with this. People will still need to be admitted through the emergency room. So don't tell the people you work with to drive to Middleborough. They need to be admitted through the emergency room. We take a wide range of insurances for these programs. For the adolescent program, it is an inpatient psych program. And so ages 13 to 17 is the age span there. We have had for years an adolescent residential treatment program in Middleborough, which is over 20 beds, and that is a step down program for inpatient psych. So the adolescent program now at Oak Street, the old High Point Hospital, is an actual inpatient psych adolescent program. So the 2 adult units, general psych, deal with a lot of post-traumatic stress disorder, a lot of bipolar disorder, substance abuse, schizophrenia, anxiety and depression, the full range of human struggles there. Do any of you have any questions about this? So
anyone has a question? Yeah, sorry, I'm just looking to see raised hands. I don't see any, Dr. Rediger. Thank you.
I think Kathleen has a question.
Thank you. Thank you. So I just want clarification, because my understanding is that, you know, rather than calling the police and going to the ER, now we are advising individuals and families to call the ESP. So does that bypass the ER at all?
No, it doesn't, unfortunately. No, and that gets into a larger issue. It's just that I don't agree theoretically with having psychiatric hospitals separate from medical hospitals. There's just a lot of physical in the mental and a lot of mental in the physical for both psychiatric and physical disorders. But that's to have our psychiatric hospitals separate from the medical hospitals requires that we need to make sure we dig into things medically before we accept somebody to our psychiatric programs. And I'm sorry, It's just a reality of a paradigm that I think has all kinds of problems, but we won't get into all that right now.
Yeah, thank you.
Yeah.
Right. For
What
the
other
adult
questions?
units,
Yeah.
for the adult units, are there any geriatric services specifically?
Not specifically, but we
Okay.
have set this up intentionally that we can take people into their 70s. We do have geriatric programs in Belmont,
Mhm.
and they're often full as well right now. So we routinely do take people in their 70s. We just think about the milieu and how to best make that mix work in the best way.
Mhm.
There are other geriatric psychiatry programs around the South Shore, as you probably are aware. Morton Hospital, BI Deaconess in Plymouth. There's several others. Good Samaritan Hospital. Milton Hospital. Any other questions right now? Okay, well, we can move on to the other part of this talk if you would like. I'll try not to be the best cure for insomnia that you've had all day, especially since it's in the morning. Let me see if I can pull up the slides here.
This is why we have coffee when we meet in person, Dr. Rediger, so no one falls asleep on our speaker.
Right. Okay, here we go. Okay. Can you all see this?
I think we're not seeing the slides.
Okay, let's
Sure,
see.
I have the. Yep.
Let's see what the problem might be here. Oh, I think I know what the problem is. I need to share it differently. The share screen is not, oh wait, here, I think I've got to do this.
You should have, oh, there we go. Great.
Okay, there we go.
All right.
Okay. Okay, can you see that?
Yes.
Okay. So my area of research is a little bit unusual. For the last 17 years plus, I have been gathering medical evidence for people who have recovered from incurable medical illnesses, and that's been a life-changing journey for me, both personally and professionally. And it's really turned upside down the way I think about health and well-being. And it's a long story about how I got into this. Back in 2003, an oncology nurse at Mass General came to me and said that she had just been diagnosed with pancreatic cancer, and she wanted my help explaining this to her son. I did that, and then she took off on this journey of changing her lifestyle and her illness at a deep level. And she went to a healing center in South America as part of that. And she began calling me saying that she was seeing some amazing recoveries and she thought I should look into it. I was a new medical director and faculty member at the time, and I didn't think anything was likely to be going on, so I declined. But I owe a lot to Nikki for this. She was persistent, and she began having people call me from around the country and elsewhere saying they had medical evidence for their recoveries and did I want to hear their stories. I said no. So because I thought they could probably be explained, but people started sending their files in, and although I could explain most of them consistent with the way I'd been trained, some of the stories I couldn't explain, and the medical evidence didn't fit into a paradigm that I was able to understand. And so the long and short of it is I did go on a journey to begin trying to understand what's going on here. And I had 3 criteria for my research, and they were pretty rigorous. I told people I wouldn't look at their files unless they had a genuinely incurable illness, according to all that we currently understand. Number 2, they had to have medically indisputable evidence for accurate diagnosis and clear evidence for recovery. And then number 3, there had to be no complicating factors. In other words, no experimental medication or anything else that could potentially explain how they got better. And initially, this research was very confusing. You know, there's people, the desire to be better is very deep in all of us when we are seriously ill. And there's people certainly who thought they were getting better and the evidence didn't show it. There's a lot of confounding factors with people who had also obtained chemotherapy or other treatments And it took quite a while. The first years were winnowing out how to really clarify who I could study and who had clear evidence, etc. So what I eventually began to see is that patterns began to appear out of the chaos of all of this. And eventually I began to realize that there's nothing spontaneous about spontaneous remission. And in med school, you're taught that spontaneous remission is a fluke with no medical or scientific value. The word spontaneous in this context means without cause. And now, in retrospect, it's also clear. I understand that that's such an unscientific attitude to think that something has no cause. Everything has a cause. It's just that we were not asking the questions. And every person I've interviewed over the last number of years made huge shifts in their lifestyle and perception. It's just that we weren't asking the questions. So I've become very devoted to the idea that it's just common sense that we should be studying the ultimate performers in health. We study ultimate performance in sports and in business, but we don't study in health. We assume that there's just nothing there to study, and that's not true. I've come to understand, frankly, as a physician, I was taught to make a diagnosis and start a medication, but by and large, we don't study how people heal, and we don't study well-being, and that's starting to change. We're in the early stages of a massive paradigm change that is exciting and is going to change the way we think about health and well-being completely, but there's a lot of work to do in terms of boots on the ground, daily work and perspectives in our clinics and our hospitals. This all has huge relevance, not just for those who have quote unquote incurable illnesses, but also for the 85 to 90% of illnesses that we treat as incurable, but in fact are lifestyle related. When I was in med school, we were taught that so much of what happens is genetic, and that's actually not true. Genes do play a role, absolutely, but genes can be turned on and off by lifestyle to a far higher degree than we were taught at the time. So the whole science of epigenetics is now gaining steam, and we're starting to realize that the illnesses that we still treat as incurable are more often lifestyle related than we have typically understood. So diabetes, heart disease, cancer, lung disease, autoimmune illness, these have significant lifestyle components that often are ignored. And that's a massive subject that we can get into more if you want at the end. So I've become very devoted to these kinds of questions and issues. Today, what I'd like to talk to you about, with you about, is the current state of Western medicine, particularly in regards to chronic illnesses. Western medicine is brilliant when it comes to the acute illnesses, but we fail miserably frequently when it comes to the major killers, the lifestyle illnesses that most people suffer from, the diabetes, heart disease, cancer, autoimmune illness, etc. And every time we export the Western diet to other countries, it's not that the rates of these illnesses go up, they go up exponentially. And I can tell you so many stories about that. It's a tragedy. I have a friend, he's a physician and has an organic olive farm in Greece. And he told me not that long ago that there's a tragedy unfolding in Athens right now, because whereas in Greece, in the outlying areas and the Greek islands, et cetera, they've been eating the Mediterranean diet for centuries, and it's a very healthy diet by and large, and people do relatively well with their health. But right now in Athens, it's now cool to get a cheeseburger, Coke, and fries, and so the rates of heart disease and diabetes and obesity and cancer are going through the roof. And I think that's just a tragedy. And it happens over and over again as we export the standard American diet elsewhere. So I want to talk about that a little bit. I want to talk about the disease model and the future of less deficit-based models. This is relevant for psychiatry as well, where we tend to reduce problems of living to neurochemistry or to deficits of childhood, and we need models that are rooted on what's right and whole and good about each individual human being, rather than just relying on deficit-based models. And then at the end, I'll do an introduction into the science of this and try not to bore you too much. Let me start by saying this is an analogy I talk about in Cured. I talk about the difference between ambulances versus guideposts. Western medicine is brilliant at picking up people who have fallen off the cliff. And we have a long line of ambulances at the bottom of the cliff that can whisk people to hospitals and to clinics and do some really brilliant work in terms of repairing the acute diabetic ketoacidosis, the congestive heart failure, suicidality, bipolar disorder, those kinds of things Western medicine is brilliant at. But it would be a whole different model of medicine if we also had guardrails or guideposts at the top to prevent people from falling off in the first place. You guys know this. You guys are the prevention staunch guidepost on the South Shore, and we just need a lot more of the way you guys are doing things. And it's a different way of thinking, but it would prevent so much of what's going on. And certainly that's the case psychiatrically as well. It's a big topic for sure. So modern medicine is wonderful and life-saving for acute injuries and illnesses, but often limited and even destructive for the treatment of chronic or lifestyle illnesses. You know, let me say this also. For years, I've been medical director here at McLean. I've also was 14 years at Good Samaritan. I was chief of behavioral medicine there. And I also was for 2 years at Beth Israel in Plymouth. And on the medical floors, we make this deep distinction as if psychiatric and medical are different, and it's just not the case. There's a lot of mental in the physical, and there's a lot of physical in the mental, and that's why I'm not a fan of making a big difference between psychiatric and medical. They are just two sides of the same coin, and we often don't see that because of the way we characterize that. And historically, there's a lot of reasons why we do this, but it's a mistake, and it's slowly being repaired, but we have a long ways to go. So nearly 1 in 2 Americans, or 45%, have a chronic condition such as heart disease, cancer, diabetes, arthritis, and asthma. Depression is perhaps, as you know, has been named by the World Health Organization as the #1 health problem in the world. And that was before COVID. It's now even a bigger problem. And of course, there's a ton of anxiety. There's a ton of trauma that goes on in the world, whether it's acute trauma like physical, emotional, or sexual abuse, or developmental trauma. And historically, psychiatry and medicine have undervalued the role of trauma in people's lives and how that sets people up for the psychiatric suffering that they have. It's more often than we realize, I believe, the depression, anxiety, bipolar disorder, et cetera, are the presenting diagnosis, but that's really secondary to a more primary diagnosis of developmental or acute or chronic trauma. And that's a paradigm change in itself there, I believe. So the rates of illness, both psychiatric and medical, are similar in many industrialized countries around the world. So it's not unique to the United States. These conditions have created an international healthcare crisis and are crippling health and healthcare systems. And this is even more sharply true because of COVID. Chronic illnesses comprise more than 2/3 of all deaths. And these deaths are caused by 1 or more of 5 chronic illnesses, as we've been discussing: heart disease, cancer, stroke, COPD, and diabetes. These are the top global causes of death and disability and account for 75% of healthcare spending. The increased prevalence of chronic disease has caused 2/3 of the increase in healthcare spending. The rates of these illnesses are skyrocketing. And as many of you might know, obesity is associated with a lot of this. The processed foods, where people are eating empty calories that lack the phytochemicals, the nutrients, the vitamins and minerals that the body longs for. These empty calories keep triggering the hunger mechanism. And so the body keeps looking for the nutrients it needs, but often isn't getting it, unfortunately. And that contributes hugely to obesity. The World Health Organization, as we mentioned, has named depression as the #1 health problem around the world, and that has just continued to increase with COVID. So many other illnesses exist outside of these most common chronic ailments. They also cause significant suffering and disability. As we mentioned, 85 to 90% of the major killers are lifestyle illnesses. And so my argument is that we need an approach that does not just tinker at the edges of traditional ways of thinking, but helps us think in new ways about the nature of health and healing. The work that you all are trying to do in prevention is so critical. We need to help this paradigm change happen in our culture. Prevention is where it's at. It's the guidepost at the top of the cliff that changes our whole approach to all of these things. So stories are great and pictures are great. So I thought I would give you some pictures and stories this morning just to give you a flavor for what's going on here. And Emily Bowler, I didn't write about her in Cured because technically she doesn't have incurable illnesses. And this research started off for many years as just a quest for truth for me. But this is a good example of lifestyle illnesses that we typically treat as incurable. And if she had not pursued a different path, she would still be struggling. Emily is an artist, and she was in Italy, actually had this really fascinating experience. She was in Italy back in 2008. And as an artist, she was looking at the statue, the sculpture of Michelangelo, or the sculpture of David that had been sculpted by Michelangelo. And she was so offended because this beautiful sculpture had been defaced in some way. And she was really upset that historically this defacement had occurred. And then she had this inbreaking realization that she had been defacing her own mind and body for her entire life, and that she needed to change the kinds of thoughts and nutrients that she was putting into her body. And around that same time, she read a book called Eat to Live by Joel Fuhrman. And after an entire lifetime of yo-yo dieting and struggling with her weight, she found a path where she didn't have to count calories. She didn't have to count proportions on her plate. She didn't have to do a lot of those things. She just focused on giving her body the most dense nutrients she could. And it turned out to be the kind of liberating path that she needed. In 2008, she was suffering. She had been through an abusive childhood. She'd been through the suicide of her son, which is a tragic story. He had bipolar disorder and probably was not just manic, but delirious on an inpatient unit, and they weren't watching his blood sugars, and it was a tragic outcome. And again, that's that whole thing of the medical versus psychiatric split. And it's often not just one or the other. But she, 2008, had this realization while she was in Italy that she had been putting toxic thoughts and foods into her body her entire life. At that point, she was taking medications for numerous chronic illnesses. She had high cholesterol, her blood pressure was high, her blood sugar numbers were too high. She was struggling with anxiety and depression and was taking medications for both of those. And trying to think what other illnesses she had. So she decided she was going to track this new way of thinking and eating. And she started, the middle picture is a picture she took of herself in July of 2008. And the picture on the right is July 2009. So that's 12 months later. She'd lost 100 pounds and she was no longer on medications for blood sugar, for blood pressure, for cholesterol. She was off of all medical and psychiatric medications. And she has just continued to unfold in a direction that's been very meaningful to her and liberating. She wrote a book. I wrote a blurb for her book that came out several years ago called Starved to Obesity. And it's a very tiny book, but it's a really clear example of how the psychiatric and the medical are tied up together, and how changing one's perception and experience of oneself gives the motivation to find a new pathway that eliminates for her the yo-yo dieting and the struggle, and provided an integrated path with a deeper part of herself that really liberated something in her. And there's a lot we can go into with her story. These stories, I'm telling you, I have to go kind of a little bit of a surface view because we'd be here all day, and I know you don't want that. There's a lot to her story. There's a lot to all the stories that we're looking at. But what you see is across all these illnesses, you see that there are identifiable factors and patterns that you see across these illnesses. And in a profession where it's in med school, we specialize in body parts. So if you're interested in the brain, you become a psychiatrist or a neurologist. If you're interested in the heart, you become a cardiologist. If you're interested in the GI system, you become a gastroenterologist, et cetera. But what we don't do well is step back and look at the big picture. I think specializations are brilliant, but we also need to do this double step of stepping back and looking at the big picture of the human person and seeing the larger story of what's going on in their lives. If you understand the story, then you understand how to intervene and help. And we often eliminate the story in order to penetrate through to the underlying signs and symptoms, and that's a massive lost opportunity. Let me tell you the story of June. I always enjoy telling the story of June. She has a great story. One of the reasons I got interested in her story initially was that we are taught that spontaneous remission is rare. And since when you find a family where there's 2 or 3 well-documented instances of spontaneous remission in one small family with really different diseases, that kind of, in the early days when I was looking into this, helps dispel that this stuff is just a fluke or something that has no medical or scientific value. So June started the pathway with her illness. She had ankylosing spondylitis, which is a really difficult illness with no cure back in I think it was the early 90s. No, I'm sorry. This was way before that. This was decades before that. Ankylosing spondylitis is an illness where your pelvis begins to calcify, and because it calcifies, you're rendered immobile, and the calcifications just go up your spine and slowly take over your body. And the tragic outcome is that once your rib cage, for example, begins to calcify, you can't expand your lungs. The ribs play a big role in expanding and contracting the lungs. And if you can't move your lungs open and contraction, you die. And so she was diagnosed with ankylosing spondylitis, and it's a long story as well. She began this pathway of, she was told by her doctor, she asked for exercises, and she looked at the set of exercises. She's a young woman in her 20s, and she said, these are for old people. This is not for me. She said that she accepted the diagnosis, but not the prognosis. And so she set off on a long journey to figure out how to heal her body. She had a husband who she loved. She wanted to have children, and she was determined to see if there is a way through and around this. Her husband, years later, he adores her, and they went on this journey together. He later had a aneurysm in his brain that he was able to heal through the same kinds of things that she did, that she had led the way on. And that was such a remarkable sort of thing that he was able to avoid surgery, and it was written up in the Neurosurgical Journal. So these kinds of things, these are amazing stories that one sees, and they certainly raise a lot of questions. But June, again, she did a lot of the same kinds of things that Emily did. Nutrition was a big change for her. She went into yoga at a time, this is back, I think, in the 70s. Yoga was not the thing that it is now, but yoga became a pathway for her. And she will say it wasn't really about the yoga, because it wasn't, because of the deep changes she made at a very deep level in terms of her own perception and identity of herself as a person and as a woman. And I wish we had more time to go into some of that. But yoga was a big piece of how she got started with things. And it was in yoga that she began to pay attention to how her body felt. And she noticed that she felt better with different kinds of foods. And that's what initially helped her begin cleaning up her nutritional program. She initially went on opiates, and she talks about how she needed the opiates initially just to calm her brain down so she could take a breath and kind of look around her at what was going on. But then she decided she needed to also taper herself off the opiates so that she could be in touch with her body as she went to these sessions in yoga and worked very hard to get in touch with her body at a deeper level. And I'm sure that these yoga poses that she was doing helped snap some of the calcifications. But again, she will assure you it's a lot more than just the yoga that ended up providing a healing path for her. So she has been completely disease-free now for over 30 years. She's one of the most vital, happy, and loving people I know. She's an inspiration. She has 3 children who are grown now. She shares her time between San Diego and New York, spending a lot of time in New York City with her grandchildren. And she does not look like she's a frozen, immovable mass. I think you would agree with that. I couldn't get close to what she does. I don't think any of us probably could. So she's really found a path that was liberating for her. And like every single person I have studied over the last 17 years, she is so grateful for the illness because it gave her such a different experience of her own value and of who she is in the world. And you can't buy that kind of deep change in one's understanding of value and the kind of universe that we live in. So it's an inspiring story. I also tell the story of Dana Lewis frequently. Her story is a little bit different. I'm also so touched by those who are developing new democratizing technologies that are liberating as well. I spoke in Austin at University of Texas in Austin at a self-help conference with a bunch of patients who weren't waiting for doctors and scientists to invent solutions for them. They were taking charge of their health. I believe that the democratization of medicine is a huge story, and that's where things are going. There's been a lot of resistance to that for all kinds of reasons of paradigm. And I think a lot of well-meaning health professionals are so locked in by what the regulatory bodies require, what the licensing bodies require, what insurance companies will pay for, and the very powerful socialization process of medicine in general. So there's a lot of things that limit medicine from participating in the democratizing impulses and human rights movements that are growing around the world, but that is finally starting to occur. And I believe in the next 10 to 20 years, we will see a dramatic paradigm shift as the democratization of medicine really begins to take off. Dana is a great example of somebody who said that I'm the CEO of my own health. I'm not going to wait for someone to invent a solution for me. She was diagnosed, I believe, at age 13 with type 1 diabetes and had a very brittle form that was putting her life in jeopardy at night when she would sleep because her blood sugars would go so high and then quickly become so low, hypoglycemic. And she couldn't exercise. She couldn't do a lot of things because of the brittle nature of her diabetes. So she decided that she would invent an artificial pancreas, and that then she would make that software open source. And so she was able to do that, and now has this artificial pancreas, which is basically a software program, and it's open source. People around the world are adapting it to their own needs, and she has liberated her own life to be able to exercise now. She sleeps safely and has a completely different quality of life because of this. And it's inspiring to see what people are doing in the self-help world as this movement begins to take momentum. I talked to one guy who invented the surgery that saved his life. There's a surgery that his mother had the same illness that he had. It was a problem with the adrenal glands, and he found buried back in something like the 1920s, a surgery that scraped out part of the medulla of the adrenal gland, if I recall correctly, and was able to get rid of this part of the body that creates hormones, but was not working correctly. And he was able then to convince a doc to do the surgery in increasingly larger animals, and then finally to do the surgery on him, which now has not only allowed him to live, but to develop a complete quality of life that never would have been possible. And now he's a motivational speaker. So you see these kinds of stories and they're just so inspiring. And you're going, wow, if these people that are making these massive changes in their lives and in their well-being, if they can do that, then maybe I could do this, And so I know personally, I've rebuilt my mind and body completely just upon learning from these people over a period of so many years and being inspired by what they've done. So this is another story, Rachel Donalds. She was at the School of Public Health in Boston and diagnosed with Hashimoto's thyroid illness, told by her doc that once the autoimmune illness destroys her thyroid, she could take synthetic hormones for the rest of her life. She didn't care for that as a solution and decided to see if she could experiment with changing her ways of relating to stress and nutrition, et cetera. And she invented an app that helped her recognize when she's in chronic fight, flight, or freeze and how to help get out of that. And has now been able to normalize her thyroid function and is not at risk in the same way of taking synthetic hormone down the road. And so that's a thing as well. I've been involved with this project. It's been through the Harvard Launch Lab, et cetera, and that might help people take charge of their health as well. Let's see here. So I'll tell you a fun little story since I got good pictures, and this is a story of someone we all know, the physicist Stephen Hawking. These stories are hidden in plain view often, and we just don't have a paradigm that helps us see what's going on here. Stephen Hawking was diagnosed with ALS, which is Lou Gehrig's disease. It's a fatal illness typically. He was diagnosed with that at age 22 and told he would be dead within 2 years, which is the typical scenario. And as we all know, that did not turn out to be the story for him. He died. He lived a life certainly very impaired, and had wives and others who took a lot of care of him and helped him live as long as he did. But he lived for another 55 years. And there are some people who know him well who say that it was actually the illness that liberated a deeper self within him to do the brilliant work that he did do. He was doing a book at the time of his death with my literary agent. And so I know some of the stories about how this all unfolded for him. And it's an incredible story. So diagnosed at age 22, told he would be dead in 2 years, lived another 55 years and died at age 76. And again, I'm not always just interested in complete healing. I'm interested in the amazing adaptations that people make. And there's just so many more solutions out there than our paradigms acknowledge or understand or help facilitate. And and when asked what helped him live so long, he said, well, keeping your mind active and having a sense of humor is really important, he believes. And we all know he kept his mind active for sure. But he also was a really funny guy. And I think that's what, in spite of the limitations of his physical frame, he attracted people because he was so vital. And I've heard stories about just how vital and alive he was and how much contact he made with people through those eyes, that he was very much alive. And humor was a big part of things. He was on HBO's show with John Oliver at one point, and they were talking about parallel universes. And John Oliver said something to the effect, is there a parallel universe where I'm more intelligent than you? And Stephen Hawking said, yes, and also one where you're funny. So that was very good. And then John Oliver says something to the effect, is there a parallel universe where I'm dating actress Charlize Theron? And Stephen Hawking said something to the effect, no, that's beyond the bounds of scientific possibility. So he was a funny guy. People were very attracted to his sense of humor, and in spite of his physical limitations, he found a way to transcend those in some important ways. Singularity University is a place out in Palo Alto. I've done some speaking there, and they do amazing work with the whole idea of democratizing medicine. And they decided that it would be a great publicity stunt to take Stephen Hawking into suborbital space a number of years ago. Their whole goal is to get to Mars, and so they do a lot of work around that. And you've heard of people like Elon Musk, and who's been associated with these efforts. So the FDA the FAA and a lot of regulatory interests were not going to have Stephen Hawking going into space, but they ended up buying multiple insurance policies and getting multiple docs to sign on for this. And Stephen Hawking really wanted to do it, and then he got up into space and he didn't want to come down. And in retrospect, of course, that probably makes some sense. He was an intrepid explorer in so many ways, but to be liberated from some of the confines of his body was probably such a liberating experience for him. So they did something like, I think, 8 rotations around the Earth suborbital, I believe. That might not be the exact number, but they stayed up quite a bit longer than the plan originally was. And it just shows what an adventurer he was. And I'm sure that's related to how long he lived and the vitality that he contained. So Amy Mullins is another prominent example that we should just understand a bit about the deeper approach that she took. She's a double amputee and is considered widely as one of the most inspiring women in the world, and also helps inspire women. She has dedicated herself to the lives of women. She has been very clear that prosthetic limbs are no longer to be regarded as functional objects, but instead should be regarded as objects of art and beauty. And she gives a famous TED talk, I think something about like 12 pairs of legs or something like that. And she was the first disabled person to compete in normal NCAA sports. She has set records. She models, she dances, she won, I think, on Dancing with the Stars years ago. She's done a lot, but she has a perspective that I think is so important. She talks about illness as opportunity, and talks about illness is what allows us to become more fully human. So some of her language around this is just beautiful and very much along the lines of where I think things are going for health in both psychiatry and medicine. She has started a conversation about the way society looks at disabilities. And she says it's no longer, quote, "It's no longer a conversation about overcoming deficiency. It's a conversation about potential. A prosthetic limb doesn't represent the need to replace loss anymore. So people that society once considered disabled can now become the architects of their own identities." That's important. The architects of their own identities, and indeed continue to change those identities by designing their bodies from a place of empowerment. It is our humanity and all the potential within it that makes us beautiful. That understanding is very consistent with the kind of work you all are doing, helping people know their value and know that they already bring something that's whole and complete into the world, and to build a foundation within themselves where they can experience that. That's the most important thing we can do. There's a lot of stories we could talk about. I've seen a lot at this point, story after story after story, and you just see the same patterns over and over, and it's just nuts that we're not helping people develop lives where they know their value and can experience that, feel seen, and then find the motivation to make these lifestyle changes that are just so life-changing. Now people often write me and ask, do you see spontaneous remission in psychiatry? And I do. This was such a journey of truth-seeking for me that I wanted medical evidence. So for my first book, I only wrote about illnesses that had clear and indisputable medical evidence, which means they had to be medical evidence, since psychiatric illnesses typically don't have the same level of biomedical markers, et cetera. But Mary Munsell at the bottom there, I do enjoy telling her story in a talk like this. She came to McLean, and she's been fine with me telling her story, and had such a dramatic change in her life. She said that she discovered hope again while she was in her program after years of chronic suicidality and being a DMH client and having DMH staff often needing to check with her daily around suicidality in her Section 8 department. She said she discovered hope again at McLean, and then she left and returned to her art, and her art healed something very deep in her. And so then, since then, many years have gone by. She has started a peer-to-peer counseling program on the Cape, centered in Hyannis, called Dancing in the Rain. And she typically fills a ballroom every year with an annual thing. And I often have given the keynote over the years. It's not always me, but sometimes it is. And she, over the years, has sent me newspaper articles about the programs that she has started to help people take charge of their health and well-being. She has spoken before the House of Representatives in downtown Boston about this kind of stuff, and just has become a real light around what's possible for people. And she's an amazing individual in terms of what she has done for herself and now is doing with others. So we should be stopping soon. I'll just say we won't have time to go into the deep science of this, it looks like, but I'll say a few things here. So the disease model was a distinct step forward during the industrial age. It enabled the rational identification and classification of diseases. These early scientists were able to take illness from the church and say, you can't blame people for being ill. You can't say their illness is a judgment from God. And that was a step forward, I believe. We've made a lot of progress with that over the last few hundred years, but as you know, especially in psychiatry and in addictions, we still have a ways to go. And it's still far too prominent to view illness, especially psychiatric illness and addiction, as a moral issue. And it's just not. I also don't think it's just a disease issue either. I think you find some degree of liberation by seeing it as a disease, but I think it's actually the next evolution. We will understand addiction and psychiatric illnesses as a learning issue, and as often related to trauma or developmental trauma, and not just a disease versus a moral issue. It's neither one of those in their fullest sense, I believe. So, but what we ended up with these early scientists taking illness from the church, it allowed them to create a classification system, a taxonomy of illness, where they could distinguish the early signs and symptoms of one illness from the signs and symptoms of another and make a good diagnosis. But it was still a science of disease rather than a science of health and well-being. And as I mentioned earlier, it's the thing I've been so slow to learn, but the light bulb finally began to turn on for me as I began to realize how deeply it's true that I was trained to make a diagnosis and start a medication, but by and large, we just don't study health and well-being or how people heal. And that absolutely needs to change, because the picture of what's possible is so different than we realize. So in my view, I tell people all the time, I do use medications, but I tell people medications treat symptoms. It's important and compassionate to use medications, especially in the acute crisis, but it's also important to treat the deeper causes of illness. And it's just so important to ask, what is the message of this illness? Whether it's physical or psychiatric, what is the message here? What is it that's out of whack in my life? And just to begin asking those kinds of questions can create a trajectory that's radically different. In the West, what's brilliant is that we are so good at focusing on the parts, but we forget the living person who lives with all these different parts. We have a medical problem. If you have a medical problem, you're sent to the physician or nurse practitioner. If you have a psychological problem, you go see the therapist. A spiritual problem is sent to the priest, rabbi, minister, or imam. And that's all brilliant and important. But if the expert and if the person themselves don't also step back and look at the whole picture, then you miss every opportunity, because there's so much we can do to galvanize a whole new relationship between these aspects of who we are, the body, mind, and spirit. If we consciously bring them together in a new way, it's shocking what sometimes becomes possible. So, the democratization of medicine. We need more democracy, human rights, self-help movements, and strength-based approaches. Doctors as coaches rather than experts on our lives and bodies. I tell people all the time that your doctor has scientific training and perhaps clinical experience, but there are things that the person knows about their life and their bodies that they need to bring into that conversation with their healthcare provider and need to make sure is part of the equation, especially since it's somebody who they often see for just minutes at a time. We need less passivity, less learned helplessness, and the smartphones are going to continue to become like the tricorders in Star Trek. And as modern physics enters medicine, and we are going to see biotech and eventually nanotechnology increasingly democratize medicine. And that's a massive subject. It's going to revolutionize the relationship between mind and body. And we will leave behind the false dualisms of Cartesian and Newtonian science, which has, we've known for 80 years, quantum physics has been proven. And it's not a theory, it's a fact. And the ideas are so massive, we're just not sure how to incorporate these large ideas into our lives yet. Peter Diamandis talks about becoming the CEO of your own health. I think that's critical, and people often resonate with that way of thinking. So the exceptions, I believe, are so important. These people who have medical evidence for recovery from incurable illnesses, treasure your exceptions. When there are none, work gets so dull that no one cares to carry it further. Keep them always uncovered and in sight. Exceptions are like the rough brickwork of a growing building, which tells us there is more to come and shows where the next construction is to be. So again, we study exceptional achievement in sports and business, and we study people like Serena Williams, Tom Brady, Michael Jordan, and Steve Jobs. We need to be studying these people in health. They have a lot to teach us. If I was ill, absolutely, I would want to know what the average person does. Our traditional models in science regress things around what's average, and they look at what the average person does. And absolutely, if the average person lives for 12 months, you want to know that. But I'm telling you, if I was ill, I would also want to know what the ultimate achievers in health and well-being do. They are screened out of our studies because they're the outliers, and we don't look at outliers, we look at the average. And so it's a very different way of thinking, but it can be scientifically based, but it does imply a new scientific model. And there's a lot that can be done. I believe it's the future. And we just need to couple that with our traditional methods so that we can begin to realize how differently these people are doing things. Certainly, we're not all going to be Serena Williams or Tom Brady, but just doing a portion of what they do is life-changing in terms of quality of life and changing the trajectory of one's health. Now it's after 10, and so I want to leave room for questions. We're not going to have time to get into some of the science of things, but at least as an introduction. And so any questions, anything you all want to talk about?
Thank you, Dr. Rediger. This is a lot, a lot in this presentation, and I'm sure we could go on for a while, but the last, this slide you have up right now, democratization of medicine, really answered a lot of my questions, because I think some of the examples you cite, folks who created their own solutions, but I think sometimes folks who have access to education or technology, and I just wonder about the equity and how we incorporate that into the systems as going forward.
That's a great question. And I was not thinking of those questions so much when I was doing all this for years, but I personally have become invested in experimenting, and I purposely tell the story in Cured about people who didn't have a lot of money or access, and they still had these remarkable recoveries. You look at people like June, who had ankylosing spondylitis, and it's absolutely true that she had access to, she could afford yoga classes. She could afford deep, she did a lot of things, more than just yoga. She did, I forget, this kind of body work that she did a lot of things. But then you got other people, Emily Bowler, who didn't have a lot of money. And I told her story. You saw her pictures with the first story we told. She didn't have a lot of money. I purposely told stories in Cured of people who didn't have those kinds of resources. And I now experiment personally in the last number of months, because I've been asked a lot of questions. Well, yeah, people who eat a plant-based whole food diet, or some people eat keto and still get better. Nutrition's a massive subject we can go into, but it's not one size fits all. It's based upon one's own individual needs. But people say, well, yeah, but that's very privileged to be eating a plant-based whole food diet. And yes, it can be. I have absolutely plant-based whole food gone the path of very expensive foods and, you know, in Whole Foods and all that stuff, and shopping just at Whole Foods. But I also have found that it doesn't have to be that way. You can eat for $50 to $75 a week. You can eat really healthy organic foods that don't have whether it's as part of that beans or frozen vegetables that are all organic and without the unhealthy salt, sugars, refined flours, and the oils, which are just pure fat. You can eliminate those and still have great tasting, very appetizing food that is not expensive, whether it's frozen vegetables or beans and brown rice or a lot of things. And it turns out that once one really begins to experiment with this, processed foods are expensive. And it's a big topic. The research around nutrition is a mess because that trifecta of industry, which pays the academics to do the studies or sign off on the studies and get certain results, and how that interacts with lobbyists and government and food pyramids. I mean, it's not just pure science, unfortunately. And so to get clear about what is unbiased science and a genuine nutritional plan that's not mixed up with all this stuff is a big topic, but it doesn't have to be that expensive. And so but you have to educate yourself a lot. I mean, I thought I knew a lot about nutrition. Turns out that what I was taught in medical school was completely upside down and wrong. And most of the docs and nurse practitioners and nurses and nutritionists that I work with have a misunderstanding of these issues. And so one does have to really invest in a project of educating yourself. And absolutely, food deserts do occur, especially in a lot of our urban ghettos. And there's massive issues around that, but it also doesn't have to be expensive.
Thank you. And I think Carol Guerin had a question. Carol, if you want to unmute yourself.
Yes, it's more of a remark. And so first of all, I just want to say what a great presentation. Thank you so much for sharing all your research. And a lot of what you're talking about is holistic health and
yes,
looking at a systems-based approach of like looking at the whole environment and everything that's affecting a human or an animal,
Yeah.
whoever's sick. And secondly, I just wanted to say with yoga is about the health of the spine, and your whole nervous system goes up your spine. So when you do yoga, you're reenacting the motions that a baby does when it's first moving around and developing its nervous system.
Huh.
So one of the reasons why yoga is so healing is because of the way you get back to breathing properly, and you're resetting your nervous system on your spine column. And thirdly, I wanted to say that what you were just talking about with the food deserts, one of the great things that's been happening in the past few years, I work for UMass Extension Nutrition Education Program, and we work with SNAP participants, which is what we used to call food stamps. But there has been a grant program called the HIP program, which set aside millions of dollars for low-income people to buy local fruits and vegetables with their SNAP benefits. So if they buy, say, $40 of vegetables from a local farmer's market, they get that money put right back on their SNAP benefit card. So there's a big movement towards getting people to eat more fruits and vegetables in the SNAP education field. And so I just wanted to add that.
That's outstanding. And I did not know that about yoga. Thank you for that. I could tell you stories about psychiatric illness that have just disappeared or had such a different trajectory created around yoga. It's shocking what can happen when the curtains part and a person has a different experience of themselves in the world. Thank you.
Yeah, it's very transformative. It's amazing.
Yeah, it is. It is amazing. What else?
Yeah, sorry. Yeah, Melissa, you put a note in the chat about this cultural RX program. Do you want to talk a little bit about that?
Sure, thank you. I'm sorry, I had landscapers outside, so I thought it was a little bit noisy. But I work in the arts, and I provide visual and performing arts programs for adults, kids, and teens of all abilities. And so throughout the pandemic, we've seen an uptick in participation in our programs. And just recently, we've been receiving some testimonials from agencies really citing how it has helped immensely with coping with mental health, physical health issues, experienced during the pandemic. And so part and parcel with that is this program through Mass Cultural Council. As we know, the arts are kind of a have and have not opportunity already. Mm. And so they're trying to provide funding for folks that have low income to be able to participate. But this is something inspired by other countries where doctors are prescribing dance classes, say for people with Parkinson's disease in lieu of just more medication. Do you see that happening more here? And what's the opportunity of insurance companies supporting that as they do in Europe?
Yes, we need a lot more of that. It's so important, and health is social at a level that we often just don't understand. And I talk in Cured about how much that's the case, how even the research around that is startling, frankly. Health is social, and people need to feel loved and seen and connected. And that's a great point. The research is clear enough that insurance should be supporting this kind of stuff. We're just not there yet. We need a paradigm change that's massive and overdue. But you're right, other countries are starting to do this. You can write a prescription in the UK for these kinds of things, and it's starting to gain momentum there.
Any other questions for Dr. Rediger?
This is Tyra. Hey, Dr. Rediger. I just wanted to say thank you for coming on, and it was really, really enjoyable, everything, all the information. I did my question or comment was similar to Mike's, just about, access. You mentioned that the first person, she didn't have a lot of money, but she was in Italy when she had her revelation. A lot of people can't go to Italy, so that cuts out a lot of people. Right. But as far as, it's going to have to be, I totally agree, because I think we do need a change in the way we manage our health and manage ourselves more holistically. But culturally, for $4, you can get at Wendy's, you can get a burger, a fries, chicken nuggets, and a drink. You can't get all those items at a grocery store. So we got to make some big changes, and you're going to be up against a lot of industries to make those things happen. But we're just like, even with us, with the CHNA, and from knowledge is power. And if people have information, then they can make better choices. But if nobody knows anything, they don't have the option to choose. So I appreciate your work and your studies. And if even a few people can hear about these things, especially now about being better and thinking better, there's so many options and so many ways to be negative, but just even think better, and the effects that will have on you, your health, physical health, and your mental health. I think those were important things to note today. And thank you.
Those are great points. I've been experimenting lately with just, using organic black beans or different kinds of beans that you can buy in these little containers with brown rice for lunch. And I read an article recently about how full that combination of brown rice and beans is for meeting a lot of the daily nutrient needs that people have. Your points are all critical, and we have so far to go with this, for sure. What other questions or comments?
Yeah, any other questions? I think we could go on for a while, because you definitely raised a lot of points. I know there was some good stuff in the chat too. And as I said, we have recorded this and we will be posting it. I know folks who had to drop off were very sad they had to drop off and wanted to have a chance to interact, but hopefully they can catch up with the recording and get some of the information that you shared with us. So Dr. Rediger, thank you so much. We really appreciate your time, and you're bringing this information to us. It's really, like I said, it was a wide ranging. So thank you again. Thank you so much. Does anyone have any announcements or any upcoming programs? I will say one thing that is happening is the Plymouth Public Library is hosting a health fair on September 25th from 10:30 to 1. If you're interested in having a table at the fair, we are kind of co-sponsoring it with them. Bethany Bergen, our health literacy coordinator, is a person to reach out to. You can reach out to me or Kim as well. We can connect you. But yeah, if you're in the neighborhood on September 25th, Plymouth Public Library on South Street, please stop by. And it's going to be a beautiful day like today, I'm sure. UMass Extension will be there. That's great to hear, Carol. Thank you. Any other announcements? Well, I don't see any more announcements. Again, Dr. Rediger, thank you so much. We really appreciate your time and sharing your wisdom with us. And
thank you for all the work you all do.
Yes, thank you all. And we look forward to seeing everyone in October. Thank you and have a great day.
Thank you.
Bye-bye now.